Yeah, yeah. Okay.
You give 70, I'll give it to you. Take it. Huh? You give 70, I'll give it to you. Right from me. How much? Yeah? How much? You say a price and you take it. I'll give it to you. You take it.
Hello. Yeah, madam. Hello.
Yes, Snehal. Yes.
Ma'am, how do I share my PPT? Because do I want basics? Desktop? I think desktop will. Yeah. Got it.
Yeah. We can see it. We can see
Got it.
Yes.
Money will be stuck in advance and you have to like, if it's gone, it's gone. I received after 6 months. I'd ordered for, I didn't have money. I ordered for Wi-Fi 64, 128. Just because I wanted, he gave me 256 Wi-Fi plus cellular. Yes. And
Hello.
So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our Head and Neck ACTRAC Saturday classes. Today's speaker is a very dear friend, Dr. Snehal Shah, who is a consultant head neck surgeon at Breach Candy Hospital, Mumbai. And he will be taking the class on the topic tracheal resection for thyroid cancer, which is a bit of offbeat topic. And I now request Dr. Snehal to go ahead with the presentation. Thank you, Dr. Snehal.
म्हणजे ते म्यूट आहे की मी म्यूट आहे आपण म्यूट आहे
Snehal, you are muted. Snehal.
Sorry. Yeah. So, good morning, everybody. Madam, good morning to you. Thank you for giving me this opportunity to speak on this. This is a topic which is very close to my heart. I have built up my own numbers on this. We'll share and we'll discuss on that also. So, I begin with our talk today. That is a tracheal resection for thyroid cancers. Now, sorry. Yeah. So, thyroid cancers, those which are locally invasive, will be involving many of the critical structures around. That's because thyroid is almost surrounding the trachea, the esophagus. So the locally invasive tumors arising from from this thyroid gland would involve the airway, that's trachea, the esophagus, the rectal nerve, that's all posterior, and the anterior, all strap muscles. Now, the surgery with the kind of space available and the margins that we are going to address are going to be very critical, because all the structures have long-term implications on the patient's outcomes eventually, the functional and the oncological outcomes both. Now, if we go for locally advanced thyroid cancers, the most common thyroid cancers that you find are again well-differentiated thyroid cancer, which accounts to more than 90%. Locally advanced account for 10 to 15% of this overall share. Locally advanced are defined as the presence of extrathyroidal extension, that is infiltration of surrounding tissue outside the capsule. So it can go anteriorly, it can go posteriorly. If you go by McCaffrey et al. At Mayo Clinic with 262 patients, that he found that the most common site of involvement after the extrathyroidal extension was muscle, that is strap muscle 53%, rectal angel now in 47%, trachea 37%, esophagus 21%, and larynx 12%. But the recent series of 2016, that is from the Sloan Memorial Kettering, this is Wang, Nixon et al. They found out that about 51% of the cases rectal angel nerve is involved, 46.4% is a trachea, and 39.2% of esophagus. Well, the rest did not account much for. This is mainly for a posterior involvement of the thyroid cancer. Now, if we go to ADCC quickly, we are going to brush up here and we're going to go to what our main topic is. We are just going to quickly go on to the surgeries, but before that, I would just like to see that what stage are we addressing in this today's talk. We are addressing stage 3 and stage 4A or stage 4B of ADCC 8th edition, which corresponds to stage 4A and 4B for ADCC 7th edition. There's nothing like stage 4C in 8th edition ADCC. This is all for patients who are more than equal to 55 years of age. Stage 3 corresponds to T4A, a tumor of any size with gross external extension into subcutaneous tissue, larynx, trachea, esophagus, rectal angel nerve. And stage 4B is tumor of any size with lymph node status with gross ETE into prevertebral fascia, that is involving prevertebral muscles, fascia, spine, and even encasing the major vessels going into the mediastinum. Now, just wanted to say that because of our current techniques, surgical techniques, and the outcomes that we give to the patient, this T4A, which was in ADC 7th edition as stage 4A, has now gone into stage 3, which means that the outcomes are better as compared to stage 4 for this kind of patients. Now, coming quickly to management, detailed history with physical examination is must. We need to watch out for symptoms. The most common symptom as per Gasset HA, which has got largest series in 2007, showed that the neck mass presentation, fixity of the neck mass on palpation, or what we can see obviously was in 37%, followed by hoarseness of voice because of the involvement of rectal angel nerve, followed by a hemoptysis because probably there could be intraluminal involvement, or there could be not only in trachea but larynx, accounting for 28%, stridor in 26% of the cases. So we have to assess for the invasion. After his history, physical examination, we have got some idea that the patient could be having a locally advanced cancer, not only by the palpation, by the symptoms, but also probably we can also feel for a fullness going to retrosternum. Probably there could be a nodal metastatic nodes which could be palpable as well, or a lateral compartment nodes. So fixity of the neck mass to underlying deep structures. Then office-based fiber optic laryngoscopy to be done to assess for the airway and the laryngopharyngeal mucosa. Now, what we can see sometimes is not only we can see a intraluminal involvement, which is as obvious, but you can also see the growth arising from the piriform sinus, or there could be just a petechiae, or there could be congested or bruised mucosa, contused mucosa, that you could see a bulge which could be seen abutting the piriform sinus or abutting into a paraglottic space. So dynamic assessment of airway and laryngopharyngeal mucosa is must. Ultrasound is done for almost all the cases, complemented with contrast enhanced CT scan to assess for degree of extension, to see for mediastinal lymph nodes, distant metastasis, and comorbidity, because that is going to fashion our treatment management. MRI is again complementary to CT scan, is sometimes done to rule out for recurrent of involvement and for prevertebral muscle involvement. Additionally, bronchoscopy and esophagoscopy is also done, which can be also done in GA. Now, bronchoscopy, coming to bronchoscopy and esophagoscopy, this is very crucial sometimes, because with a maybe rigid or maybe fiber optic bronchoscopy, we need to know how much of the excision is required of the tracheal rings. So with the fiber optic bronchoscopy, we see how much is the distance from the vocal fold down to where you see the bulge, and how much is it extending from the carina upwards. So normally the excision is wandering above and wandering below the growth, and hence we like to measure that. So fiber optic bronchoscopy, either under local or under GA rigid, is must to be seen to map our tumor, to understand how much excision is required and what could be the plan of recon. Esophagoscopy is also done to see for esophageal involvement, because these are the tumors, when they have posterior extension, will cross the planes of recurrential nerve, will go on to trachea and onto the esophagus. Echoendoscopy, or what we call as the EBUS, endobronchial ultrasounds, are also equally important, because they will also help us to assess the tracheal lumen. More than tracheal, it will asking for esophageal involvement. It is not as sensitive as compared to CT scan, they say, for assessing the tracheal luminal involvement. But yes, it not only gives us the idea about the esophageal mucosa adventitial involvement, serosal involvement, to certain extent the tracheal involvement, and also the mediastinal nodes, or to map the soft tissue around. So EBUS is done in almost all the cases. How do we assess? Sometimes we also do a PET CT scan. Now, PET CT scan will have to prognosticate what we call the flip-flop phenomenon to detect for distant mets. Now, why PET CT? Now, locally advanced tumors could be poorly differentiated, de-differentiated, it could be aggressive variant, it could be anaplastic. So more is the uptake of on a PET CT indicates that this may be less radon avid. Now, this is actually how locally advanced behaves. They are radioiodine resistant by and large. They are having aggressive biology, and this will help us to prognosticate. It will also help in picking up the distant metastasis. This also helps us to evaluate how much is the tumor burden. So major to local advanced tumors are differentiated, aggressive, and area resistant. So again, considering that, our philosophy has to be to achieve R0 resection more than R1 or R2. But again, we need to take into account other factors, like how much is tumor burden, how much is the distant metastasis, how much is this surgery going to be morbid? Is it going to be a recurrent? Is it in a recurrent setting? Are we seeing, or we are seeing in a per parameter setting that we are seeing a locally invasive thyroid cancers involving the trachea? Now, coming to a pattern of invasion by Shin on a pathological specimens, classified tracheal invasion into 5. There are 4 stages, but there are 5 stages overall. The first is stage 0, where the tumor is confined within the organ, that is within the thyroid gland. Stage 1 is when it is abutting the perichondrium. Stage 2, when it goes beyond the perichondrium, that is in the intercartilaginous rings, it passes along the what we call as a locus minoris resistentia. That is a space along the lymphatics between the 2 rings, where through which the tumor would not only involve the cartilage, it will also go on to submucosa. So that is stage 2, where there is involvement of a cartilage or intertracheal ligament, annular ligament, what we say. Stage 3 is when it goes up to submucosa or lamina propria. And stage 4 is when it will have an intraluminal involvement. Now, not only is Shin followed, but even Zaza et al. Gave their own staging system for airway involvement. But stage 1 was extrathorough extension, adherent to airway with no gross invasion, almost like Shin 1. Stage 2 is gross invasion, which can be accessed without mucosal disruption. So this Zaza gave from the point of view of our surgical strategists that will the particular procedure, in order to achieve a positive or a negative margin as a resection, will lead to mucosal disruption or not. So stage 2, the gross invasion which can be excised without mucosal disruption. Stage 3, gross invasion which requires mucosal disruption to excise but no intraluminal invasion. So stage 4 was gross intraluminal invasion. So by and large, as Shin was pathological classification, Zaza was more or less on table as to how much resection would be required for this particular tumor. By and large, if you see, majority of times when you open the field, you discover the involvement of this critical structures like trachea and esophagus. Although investigations are done pre-op, these are many times a surprise on table. So Zaza, based on those observations, gave this classification from stage 1 to stage 4. Now, just to add up, not only will this thyroid carcinoma involve trachea, but will also go on to larynx. And how does it go to larynx? So anterior and posterior route, anterior to cricothyroid membrane, and the posterior, it will go posterior to cricothyroid joint. It will go along the paraglottic space and piriform sinus, leading to bulging, or it will be at least adherent to the thyroid lamina. So this is how the tumor spreads, basically from the thyroid gland onto the larynx. Majority of times, what you find is a cricotracheal invasion. More than a classical tracheal invasion, you find a cricotracheal invasion. So the defects are fashioned along the cricotracheal defect that you give for this kind of lesions. Now, this is endoscopic image of the same patient that we did under anesthesia, under the disease evidence of hypopharynx with the PFS. Now, this would at least require a partial laryngectomy, partial laryngopharyngectomy more than doing a total laryngectomy. Now, going further to the management, we need to get a tissue diagnosis. So ultrasound guided FNAB is of choice, so as to see for the areas of poor differentiation. But again, this is again going to be like a mirage. Many times, the areas of poor differentiation are found at the area of invasion, at the point of invasion. It is never found along the whole gland. So often it is found on table when we do the biopsy and send it for a frozen section to rule out whether this is a poor differentiated or if this is anaplastic or what it is. So basically, ultrasound guided FNAB at least will give us the idea whether this is a lymphoma, anaplastic carcinoma, or could be a dedifferentiated or aggressive pathology of thyroid cancer. A thyroid cancer will be by and large heterogeneous, with heterogeneous areas of differentiation at various points, especially for locally advanced, not for the garden variety papillary cancer that you see. So coming to the philosophy of surgical management, how does a locally invasive thyroid cancer spread? So it abuts the trachea. Now, from there, after abutting the perichondrium of the trachea, it is going to go initially craniocaudally. Then it is going to go in between the rings and reach the submucosa, where it will not only go circumferentially but also craniocaudally. So we need to take into account that what we see from outside, the luminal involvement may be lesser, or when we do FOB, if we see just a one ring or two rings of intraluminal invasion, we are supposed to get the idea that probably the outside, the external spread will be much more beyond what we see today. Now, this is in brief a surgical strategy for the patients who have the locally invasive thyroid cancer involving trachea. So again, this is based on Shin et al. And McCaffrey, and this also shows what are shave procedures, and we'll come on to that. What are the indications for shave? What are indications for sleeve resections? What are the indications for window resections? But this is in brief nutshell about what is going to come further. Now, why do we need to go for a R0 resection for this tumor? So if we see, so by and large, if we visit data, all data, almost all data are based on retrospective analysis. None of the data are prospective based. None of them are randomized controlled trials. So the data what we have is always we need to interpret with pinch of salt. The reason is what kind of patients have been taken into the effect into the analysis. First, because of it being a retrospective data, we are going to have a selection bias. Secondly, some authors have taken only per primum advanced thyroid cancers, and others have also taken into account as salvage procedures. Salvage procedures are more morbid, they have a poorer outcomes as compared to per primum. Third, what kind of pathology have taken? Some have they taken into account? Some have taken just some of them have taken just papillary cancers, others have taken papillary follicular, or it could be even aggressive variants, anaplastic carcinomas, whole differentiated thyroid cancers. So there's a lot of selection bias, lot of errors in it, and hence we will take every data what comes out for this with a pinch of salt. We're not going to be we are going to have our own strategies and our own philosophy behind what we do. But the idea is to achieve R0 resection. All the studies have strived to R0 resection over R plus. So if you see Brockhoff, that is Henning Drahl, a German study, retrospective study of 174 patients, 82 underwent a transmural resection. Transmural meaning either window resection or a sleeve resection, and a non-transmural in over 65 patients. R2 resections were seen in 27 patients. On resection, R1 was seen in 9% transmural and 23% non-transmural resection. Mean follow-up was 35 months. Loco-regional recurrence rate was 46% in R+, while 15% in R0. So getting R0 led to less number of recurrences. This was statistically significant. 10-year survival came down from 65% for R0 to 27% for R+. Now, coming to recent study by Wang et al., again a retrospective study, 153 patients with accessory extension. After surgery, 13% had R2, 41% had R1, and 45.8% R0. They had a follow-up of 63.9 months. The 5-year disease-free survival was not significant between R0 and R1, but between R0 and R2, it was quite significant from 94.4% to 67.9%. So there is always a push to get a R0 resection. But again, we need to take into account the patient factors, the tumor factors, and of course the technical factors before we decide as to how much is good for the patient. Is the surgery going to be more morbid or the surgery is going to be lesser morbid? If lesser morbid, we go ahead. But if the patient has got extensive metastasis, there is no point in excising a huge large segments of trachea and giving a morbidity and subsequently a mortality for this patient. Now, coming to surgical strategies for a shallow resection, shallow invasion, this is mainly for Shin 1, less for Shin 2, Shin 3, Shin 4, but shave resections for by and large all Shin 1 is nothing but scraping of tracheal wall at the invasion site tangential to trachea without opening the lumen. There is always a risk of leaving behind the R1 resection, R plus disease, that is a microscopic disease which could be left behind in this kind of shave resections. The rate of recurrence is around 5% over 7 years. Approximately 4.6 to 5%, and the local control rates are 95 to 100% across various studies. Now, is shave resection good enough? So here is a Ito's paper from Japan. They had a retrospective study from 1987 to 2004. 177 patients out of 6,000 are the patients with minimally invasive disease. All underwent shave resections. R0 achieved. So they achieved R0 resection in 107 patients. R1 in 20 patients, local recurrence was 4.6%. Now 6 patients, total 6 patients had local recurrence, 1 from R0 and 5 patients from R1. So the recommendation was to achieve a R0 resection, but even if and to achieve a surgery with a lesser morbidity. Sorry, yeah. Again, Anton Warkowski came up with a meta-analysis for a shave resection, where they compared shave resection versus radical resection for a low volume disease, tracheal disease. For 6 studies were analyzed, 24 patients, 10-year overall survival was 82.4% versus 80.8% for radical resection. So again, if you compare a shave group with the radical resection group, there was no statistical significance. So they did recommend the shave group, shave resection is good enough for a control against radical resection, which has got more morbidity, more complications. 10-year local control was 90.2%, and there was no statistical invasion, the difference between the groups that you can find. Now, again, coming to Kim's study for prognostic factors of a locally invasive well-defined thyroid cancer involving trachea, they again found that shave resections again did better than radical operations in terms of disease-specific survival, if you see. But again, those were not statistically significant. So these are all retrospective studies with lot of biases, lot of different selection criteria. Heterogeneity is there, which is quite significant in all of this particular kind of studies. Again, this study, again, they compared shave operation versus tracheal resection versus protangiectomy for disease-specific survival. And again, they found that shave resection almost 100%, they did better. But what was the selection basis on which they put? Those with lesser disease were put and were given shave resection, and those with the extensive disease were provided tracheal with the radical resection. Also, again, this group also took into account that those who underwent a revision surgery, salvage cases, where they underwent a radical resection, even though they were amenable for shave resections. So radical resections in a backdrop of salvage setting always had a poor prognosis, and hence BSS was lesser for a radical resection versus shave surgeries. Now, surgical strategies for deep invasion. Now, strategies are devised to get margins free, but associated with surgical complexity and significant functional impairment. Window resection is a partial resection with a safe margin in the area of tracheal invasion. The creation of tracheal fistula is must, which are then closed in multiple settings. So if the defect is less than 1/3 of circumference, we do construct with local flap. If defect is more than 1/3 circumference or up to 4 tracheal rings with anterior or anterior defect, recon with the cartilage and soft tissue required to prevent the collapse. Again, the multiple settings are required. The disadvantage of tracheal window resection is there is a high chance of anastomotic stricture. There is a high chance of laryngeal stenosis, laryngeal nerve, bilateral laryngeal nerve palsies. There could also be a tracheal innominate fistulas. So not only you do a tracheocutaneous fistulas, you do tracheoinnominate fistulas. Also, the closure is not cosmetic. So the wound, open wound, doesn't look good enough. But window resections are in a way lesser morbid as against the end-to-end, that is sleeve resection that we do, because of various reasons that we are trying to be more conservative and we are achieving our margins. Sleeve resection, full circumference resection involving incision of annular ligament between tracheal rings. End-to-end anastomosis is done. Performed window resection gives, so when we do window resection and that gives positive margins at the cut cartilage edges, it will we convert this into a full sleeve resection. Otherwise, when we have done a window resection, otherwise we also do a front straight away a sleeve resection when we know the tumor is locally invasive, involving almost more than 50% of the circumference of the tracheal ring. Window resection and sleeve resection. This is a pictogram. This is in brief that what we do is window resection. Figure A, figure B is sleeve resection, and figure C is a step-like sleeve resection. What is step-like sleeve resection? With the first tracheal ring. This is basically for a deeply invasive cricotracheal tumors from the thyroid cancer, where we are trying to preserve a unilateral or a contralateral recurrential nerve. So we give a step-ladder fashion, trying to save a cricothyroid joint on the opposite side, and we do a anastomosis which is end-to-end. So these are the techniques, because recurrential nerve in palsy or the injury is quite high when you do a end-to-end when you do a sleeve resection, especially with the kind of incision which is shown in figure B. That is more like a bayonet shape. This is a Grillo's technique. If you see a B, it is by and large a Grillo's resection where he gave a bayonet line, and if we cut bayonet along the bayonet line, along the cricotracheal, the cricothyroid membrane, he drew a bayonet line, and we cut along that, there is always a chance that the recurrential nerve on both sides would get injured. Unilateral side would get sacrificed, but the contralateral side would also get injured, leading to a permanent tracheostomy. Now, tracheal defect ranges and reconstruction methods is very simple. If less than 1/3 or 1/3 tracheal circumference defect, we will close it with a soft tissue flap. If it is going to more than 1/3 to 1/2 circumference, and up to 4 tracheal rings, we will go for a window resection where we'll try and reconstruct with the cartilage. Cartilage could be, I would say, a septal cartilage, or it could be a auricular cartilage, costal cartilage, or it could even be a perichondral flap on the sternum, which is normally used to give a rigidity and prevent the collapse of this soft tissue inside on inspiration, which would happen if you don't give a rigid reconstruction. So that is figure B. Figure C, the tracheal defect exceeds more than 1/2 of circumference. There will require not only to build up the anterior but also the lateral tracheal wall, which will be required to be reconstructed so as to prevent the collapse. But again, these are fraught with a lot of complication and morbidity, which we'll discuss subsequently. Now, this is in brief the indication and limitation of surgical approach. Sleeve resection combined with end-to-end anastomosis for deep invasion, circumferential direction invasion exceeding more than half the circumference and more than 4 rings. But the contraindication is partial resection of cricoid cartilage, 1/3 circumference, because if there is resection of if there is more than 1/3 circumference on the cranial side of cricoid cartilage, we would have to convert this also into a laryngeal resection, do a partial laryngectomy in addition to resecting the tracheal rings. And up to 8 rings, 4.5 centimeter longitudinally is safe. Now, risk of serious complication is there: anastomotic dehiscence, anastomotic leaks, anastomotic strictures. There could be laryngeal strictures. There could be fistulas, which could happen after sleeve resection. Coming to window resection, combined with the construction of tracheal fistula, deep invasion for stage 3, stage 4. Again, limited resection. Circumferential limitation will be up to half of circumference, longitudinally up to 4 rings. Beyond 4 rings, or invasion of membranous portion would become a contraindication for a window resection. But again, a multi-stage reconstruction. Multi-stage reconstruction is done with soft tissue, which could be a DP flap. It could be a deltopectoral flap, which could be used for a good reconstruction, or it could even be a pectoralis major myofascial flap. Coming back to extensive window resections, if the window resections are extensive, involving anterior and the lateral wall, we also prefer to do a free flap. That is, we do a radial forearm artery free flap, and we also give a rigidity to the structure with the costal cartilage or with the auricular cartilage that we take. Coming to shave approach, superficial invasion, small range invasion to annual ligament or tracheal cartilage, lesser invasive. It is lesser invasive, almost no complications as against window and sleeve resections. Now, prognostic factors for a locally invasive well-developed thyroid cancer involving trachea, if you see, so this is the article which also looked into are shave resections versus radical surgeries, which are better ones, or are they going to influence the recurrence? So this was again a retrospective study, and on a multivariate analysis of these factors, where they took into account into the analysis, multivariate analysis, age, sex, tumor size, lateral cervical node, history of previous thyroid operation, involved organs, intranominal, shaving operation or radical operation, none of the factors were found to be statistically significant. Okay, again, lot of selection bias, and we need to interpret this with a pinch of salt. The trend towards favorability was history of previous thyroid operation. So if there was a history of previous thyroid operation, chance of recurrence was higher, or if there was involvement of esophagus. But otherwise, all the factors were no clinically significant. No significant. Again, coming to a recent meta-analysis and systematic review by Allen, he took into account 96 studies, 1,179 patients. All patients underwent either window resection or circumferential resection or sleeve resection. And they found that the local regional recurrence rate was lesser for a window resection as against sleeve resection. Overall survival was not statistically significant. There was 77.1% of window resection versus sleeve resection having 74%. So yet the appropriate indications for window resections are not clear. But if you go back to the prior slides, I would take into account if there are less than 4 tracheal ring involvement, anterior tracheal ring, anterior trachea involvement, or less than 1/3 circumference, I would still prefer for a window resection over a sleeve resection. That could be we need to take those indications briefly into our account. But do a window or do a radical sleeve resection, they're almost similar. But again, if the disease is quite extensive, invasive, they are not going to do well, which is again reflected with OS of 74% versus 77.1% for a window resection. So again, a selection bias, but yes, they selected tumors with unfavorable pathology, with extensive disease for sleeve versus window. Obviously, they would not do well as against those with limited intraluminal disease or limited disease limited onto the cartilage. Now, so this was a pooled overall survival rate for a window procedure with a diamond shifting towards the right side, and 77% was what we found out. Again, this was for circumferential resection towards 74% favorable. Overall complication rates across various literature for this surgeries for sleeve resection was 15 to 39%, mortality rate was 1 to 2%, anastomotic dehiscence 0.0 to 11%. But apart from anastomotic dehiscence, there could be arterial rupture, that is your tracheal fistula, which is opening of mediastinitis, bilateral recurrence of paresis or palsy. There could also be pneumonia, mediastinitis. So these are all going to be the complications which are going to arise from this sleeve resection that we do. Many times the technique of sleeve resection is modified. We will try and exteriorize the tracheostomy down below the sleeve, below the anastomotic side, just as to prevent mediastinitis. But probably that itself would spill over and lead to pneumonias. Now, complications, anastomotic dehiscence, most commonly due to local infection from tracheostomy that we do lower down, and excess tension at site. So how much tension is acceptable at the anastomosis? So the answer to this is about 1,000 to 1,200 grams of tension is what the anastomotic site tolerates. Beyond that, it is going to lead to dehiscence. And following window resection, again, because of the recon that we do and the cartilage, what we use, the cartilage or the soft tissue that we use, those are not of same consistency as tracheal cartilage, and that's why the ciliary movements are going to be affected, and this will lead to sputum accumulation. Some people have died because of drowning in their own secretions, because they are not able to clear out, leading to mortality. So sputum accumulation, scab formation. So window resections, when you do, you need to undergo a bronchoscopy multiple times, not for just observing for the tumor recurrence, but also to remove the scabs, because it is difficult for people to expect out the scab because of no ciliary movement. So this can again lead to asphyxiation. So adhesions, sputum accumulation, scab formation, granulation tissue. Sometimes what people do is, not only will they do a rigid reconstruction, they will also put a T-tube to maintain the patency, to prevent it. But again, this T-tube, Montgomery tube, has got the complication of, or what I will say is, those can get migrated, or those can get extruded as well. So this is again a problem. So stent for a long period of time will also lead to these complications. So this patients require multiple sittings, multiple bronchoscopies, not only for the disease, but also to deal with this kind of complications that they have. Window resection, major complications, if you see, the pooled rates of major complication rate for window is 19.8%. That is airway leak, airway stenosis, respiratory failure, recurrent palsy, etc. Sleeve resection, again, the major complication rate is 14.1% for a major complication rate for the sleeve resections. Now, this is something which I'm sure everybody wants to know. How much is the gain of length of trachea that is acceptable, or how much after anastomosis we have resected the trachea as per the requirement of disease, and now how do we recon it? How do we do a reconstruction? So we need to do a tracheal release maneuvers. There are various tracheal release maneuvers available. The first and foremost is dissecting the pretracheal plane. Simple, should be routine. Neck flexion provides length for most tracheal resections. Laryngeal release adds length for proximal tracheal resection. Hilar release for distal tracheal resections. So laryngeal release could be DDoS, intralaryngeal release, or it could be Montgomery's suprahyoid release. We are going to discuss this in detail now. Now, coming first to the dissection of pretracheal plane, we don't know how much gain of length it gives, but it definitely helps us in mobilizing the distal trachea. By how much length, we don't know, but it is done for every case. Second, neck flexion. 15 to 35 degrees of neck flexion will add on a length to 4.5 centimeters. So a neck flexion and taking a chin stitch after the reconstruction to prevent the dehiscence, or just also not only to prevent dehiscence, the main purpose of giving chin stitch, that is taking the stitch with a suture from the soft tissue of the chin onto the sternum. It is also to make the patient remind that he's not supposed to extend the neck, because that will again help in reducing the tension at the anastomotic site up to 1000 to 1200 grams. So neck flexion with the chin stitch is what we do for almost every patient, because it helps us to maintain the anastomosis, prevent the dehiscence. This is chin stitch that we have taken with the neck flexion. This is by and large kept for a period of 7 days. 4 to 7 days is what we keep. And once it is settled, we relieve the patient, and patient is also trained by that time to maintain neck in a flexion, not in extension, till the anastomosis heals. Okay, now this is suprahyoid laryngeal release involving dropping of hyoid bone by the division of stylohyoid. So this is a Montgomery's suprahyoid laryngeal release, where suprahyoid we are going to excise, or we are going to release the attachment of myelo, of geniohyoid, genioglossus, and stylohyoid. But we are going to maintain digastric attachments, and we are going to remove the body between the two lesser cornus. So the body of the hyoid is going to come out between the two lesser cornus, and we are going to release the structures. This is going to give us a length of 2.5 centimeters. This is suprahyoid laryngeal release, which is nowadays done over a Dido's maneuver. Dido is nothing but the intralaryngeal release, or what we say is a thyroid release. So what we do in Dido's is that Dido, the thyroid muscle is separated from thyroid fascia. Then we cut the superior cornu bilaterally of the thyroid cartilage, and we retract the thyrohyoid and the sternohyoid, the omohyoid and the sternohyoid muscles. This is also going to drop the larynx down and give an add-on length of 2.5 centimeters. But Dido's is not done nowadays because of increased chance of aspiration and ovoidinophagia, which would take at least 3 to 14 days to settle. But both complications are done away with suprahyoid release, giving equal length of the tracheal length up to 2.5 centimeters. And hence, the Montgomery suprahyoid laryngeal release is done by and large. Now, this is pericardial release. Pericardium is open in C-shaped fashion. So what we discussed about before that was for a release of a proximal trachea. But if you see for a distal trachea, if you want to read a distal trachea, then what we do is a two maneuvers: right hilar release and pericardial release. So right hilar release, we will release the inferior pulmonary ligament going down. This will cause a release of right hilum. And if that incision is taken higher up into the inferior pulmonary vein, will also cause a release of a pericardium. So a U-shaped incision is given along the pericardium, and we dissect the superior pulmonary artery, main pulmonary artery, and the superior pulmonary vein. And this will again add on, give us a length of a distal trachea upwards. So in brief, cervical flexion, degree of cervical flexion 15 to 35 degrees, 4.5 centimeters. Some people say if you can flex more than 35, it will also give us to 5.5 to 6 centimeters. For larynx, laryngeal, Dido's and Montgomery 2.5 centimeter each. Hilar release, divide pulmonary ligament, mobilize right hilum 3 centimeters, pericardial dissection 0.9, division of reattachment of left main bronchus 2.7. So totally 6.6 centimeter of release that you get. So the most common question asked in Viva, how much length of trachea, how much maximal length of trachea can be excised? Now, if you see maximum, it is 58.7% of total trachea, which accounts to about 13 rings of trachea, which accounts to almost 5 to 6 centimeters of trachea, which can be cut and which can be anastomosed safely with end-to-end anastomosis. Now, step-like sleeve resection. Resection line that preserves first tracheal ring on a healthy side, protects tracheal nerve. This is basically for tumors which are in the cricotracheal region. Cricotracheal involvement will require excision of a cricoid, and hence, and this will again lead to injury to the both side tracheal nerve, leading to permanent tracheostomy. And that's the whole point. We will preserve, will protect one side tracheal nerve. So trachea is then anastomosed to the remnant of cricoid or to the remnant of larynx. Now, something novel which has come out are the two type of techniques. One is what we are reading currently is a windmill resection and Tetris reconstruction, and the other is a modified spiral tracheoplasty by Wu. Now, coming to a windmill resection and Tetris reconstruction, for the intracricotracheal invasion. This is for the cricotracheal. See, cricotracheal involvement is maximum. It's a presentation that you see in maximum number of patients. You will not see isolated tracheal involvement, only 2-4 rings, only without involvement of trachea by and large. You will without involvement of cricoid. Cricotracheal is by and large you will find in majority of the cases. So thyroid carcinoma involving laryngeal lumen, less unsightly wound. So it will this technique of resection will lead to less unsightly wound at the tracheal fistula. How it is done? Now, after we have done a window resection, so this is a part of a window resection. What we do is diagonally opposite lower part of trachea is resected, and we do recon. We do a recon with the larynx. We do see with larynx, and the lower part is twisted like a Tetris. Tetris. What is Tetris? Tetris. Just type to Google it. It's a kind of a video game where you join and you remove the parts. It's a just go on Google and just Google it this that the Tetris video game, and you'll see how the lower segment is connected to the upper segment. So Tetris, so windmill resection is when the diagonally opposite lower part of thyroid cartilage, of trachea is flipped above to recon the window resection defect, and then laryngotracheoplasty is then done through a Tetris recon. Second, modified spiral tracheoplasty, again for extensive window resection. So as we again talking about a window resection indicated for less than 1/3 or to 1/2 circumference and up to 4 rings. But if you are going beyond 4 rings, more than 4 rings of window resection, and more than half of circumference of trachea, we will go for a modified spiral tracheoplasty where we'll give a tracheocutaneous fistula compulsorily, but we are going to rotate both the cut ends. We are going to dissect the trachea of the esophagus for 2 centimeters, preserving recurrential nerve, and we are going to rotate the lower end of the trachea and try and suture the lateral and the posterior wall, but keep the anterior wall open, which is leading to a tracheocutaneous fistula. This is given by Otsuki, and this is then tracheal fistula is then going to be closed like we do a window resection in multiple sittings. So spiral tracheoplasty given by Wu and Otsuki gives modified spiral tracheoplasty. Now this was everything for curative to achieve R0, but there are situations where you would also like to address the intraluminal involvement for in a palliative way when other factors are not helping patient with the radical resections. So how do we take account of this? So by and large, if you see a death which happens for the patient with this kind of invasion, is there will be a bleeding, intraluminal hemoptysis, massive bleeding, and patient is drowning in his own secretions. So if the indications are not such that you will prefer radical resection, you will go for a palliative management, and the palliative management is something which is done endobronchially with the laser. Let's go and visit that data. So indications for endoscopic tumor ablation for a laryngotracheal intraluminal invasion secondary to advanced thyroid cancer. This is again, so Japanese have done a lot of work on trachea. So indication is radical surgery contraindicated because of patient refusal, extensive local disease, there is a redo, there is a salvage, there is a recurrence of the thyroid cancer, and there is a huge load where you will feel that the resecting the local site will be more morbid. So extensive local disease, patient refusal, extensive distant metastasis, poor physical condition, will go for endoscopic tumor ablation. Or if there's occlusion of more than 50% of intraluminal involvement, so in the second indication, occlusion of 50%, more than 50%, is you would like to debulk it. And then once you have debulked it, then you like to go and do a thyroidectomy along with tracheal resection. So occlusion of more than 50% initially to begin with, just to buy some time. Or if there's more than 3 months of elapsed in case of retreatment, again, those patients will not do well. Now, clinically suspected anaplastic carcinoma due to rapid enlargement of neck, this sometimes is an indication to do a endoscopic tumor ablation when you're not able to do a tracheostomy. But again, this is a relative indication, more or less is procedures. We try and get a now. Ablation is done with ND-arc laser directed via 600 micron diameter with non-contact probe. We maintain the beam parallel to airway axis leading to airway dilatation without perforation. But using an ND-arc laser will lead to bleeding. And to coagulate this, we use an argon plasma coagulation with microwave coagulation therapy using an endoscopic ball type electrode to target a flattened residual tumor tangential to airway. But in case of progression of disease, either intraluminally or due to increased extrinsic compression, T-tube stenting or expandable stents are placed. So we don't put stents initially. We debulk it, we flatten, we do coring. We core out the tumor with the laser. We achieve coagulation and we keep the patient on observation. We 6 monthly, because this is thyroid cancers are by and large considered as indolent cancers. At 6 months and at 1 year, we do a check scopies to see whether there has been again internal involvement or not. By and large, the scene, what happens here is that you will not have intraluminal involvement, but you have extrinsic compression, which is leading to luminal compromise. Because intraluminal you have taken care of, extraluminal you have not taken care of. This is going to increase in size and it's going to compress. So again, you will need to go ahead and put a T-tube stenting or expandable stents are put. Now, same group did a study for 22 patients. Follow-up was between 4 to 125 months. Median survival was 50 months, and they found that those who did not require retreatment for more than 1 year did better survival as compared to those which required them to redo or to again give a tumor ablation in less than 1 year did poorly. Again, of course, there is no rocket science to this. Those tumors are locally aggressive, but will recur within less than 1 year. Now what happens? This is done. Palliative management, curative management. Now, in the bid to resect, to give curative R0, you will end up resecting a huge length of trachea, and you have nothing. You have no other maneuver more than say more than 7 centimeters, 8 centimeters trachea resected out, or for that matter, you don't have other. Your release is not adequate, and you need to do something. The idea you have anticipated that prior. The idea is to go with a tracheal transplant. So the tracheal transplant started from 1945, where they used fascia only, to metallic wire mesh gauze 1950, silicone tube in 1976, hetero or ortho allo transplant 2016. This hetero, ortho, allo transplant, cadaveric allo transplants are the transplants of choice today when they do a tracheal transplant for the patient. And what are the indications? These are the indications. Tumor invasion, stenosis, trauma, congenital stenosis, tuberculosis, prolonged intubation, others. More common in adult than pediatric, more in male than female. These are done more commonly by Europe than in North America and others. So these are engineered tracheal replacements, and this is presented by Grinley and Nicholson. Now, according to Grillo, what is the ideal tracheal transplant? Those which are safe, non-immunogenic for implantation, mitigate stricture formation. But this is all in these are the definitions for an ideal situation which almost never arises. Repeatable, reliable surgical techniques prevent secretion, accumulation, infection, adequate suture strength over time to prevent dehiscence. Grillo said it should be straightforward, repeatable surgical technique, biocompatible, non-toxic, non-immunogenic, non-carcinogenic, avoid bacterial colonization, accumulation of secretions. It avoids accumulation of secretions, avoid bacterial colonization, granulations, chronic inflammation, laterally rigid but locally flexible tube, permanent airway structure, no dehiscence, erosion over time, and support respiratory epithelium. Believe me, these criteria are not met with in today's world. Wherever you go, they are fraught with morbidity and subsequent mortality as well. Okay, now maximum follow-up by the scaffold. So maximum follow-up that you see here in the figure above is for a heterotopic orthotopic allo transplant, which is 75. So I'll tell you in brief what they do in heterotopic or orthotopic allo transplant. They take a cadaveric trachea. That cadaveric trachea is then implanted onto the forearm or onto the leg of the recipient. Why is this done? Because they found that it is not graft versus host disease that leads to failure of this transplant, but it is due to inadequate vascularization of this particular graft that it fails. So we need to build up the adequate vascular supply for this particular graft and then do a transplant into the trachea. So orthotopic transplantation is done onto the patient's body. Patient is given immunosuppressant. What we say is a Leuven protocol. Leuven protocol will consist of provision of three immunosuppressants, that is methylprednisolone, mycophenolate mofetil, and tacrolimus, and that is given for a period of 3 to 6 months. Once that is achieved, then you do a transplant. But believe me, even then the failure rates are lesser, but they are still there. So what to do further? Because not only are we taking into account the decreased vascularity, but also host response, immune response, and then comes what we say is a aortic autograft. Aortic autograft, taking one's own aortic segment and then doing a transplant there. But again, the kind of rigidity that would be required is not reached. So further going beyond aortic autograft, we went for a decellularized allografts. Now decellularized allografts are what? So these are the allografts, cadaveric allografts, which are washed with various enzymes and with various detergents, and they're decellularized, and they're again transplanted orthotopically transplanted, and again given a immunosuppressant, and again they're put back. So these are something which are coming in, but the data is still scanty, scarce. We need to wait for more results. Now, now these are the cause of mortality in the patients receiving tracheal transplant grafts. So again, in today's times, as we go from 1960 to 2020, it is mainly because of dehiscence that you see the mortality more as compared to any other causes, say secretion, stricture, collapse, migration, infection, etc., etc. Now, my experience, I came out from Tata Memorial after 8 years, and it was for me altogether new atmosphere. And of course, I got a lot of guidance from madam, not to say the least. So she helped me with a lot of guidance how to go about my practice. So since 2020 till date, I have addressed 7 patients, locally advanced thyroid cancers, 1 anaplastic plus 6 papillary cancers. I did window resection for 2 patients, reconstruction with PMF, and other with the other one with 3 costal cartilages. So by and large, 6 costal cartilages is a maximum limit that you can harvest costal cartilage. So I took 3 costal cartilage with PMF, I sutured it to each other, and this 3 costal cartilage sutured to PMF, and so as to give rigidity to the tracheal wall. I did sleeve resection for 1 patient with end-to-end anastomosis. Esophageal involvement was seen in 1 patient where I did shaved off muscularis and adventitia. So in 2 patients for esophagus. Tracheal shave resection was done in 3 patients. I did a partial layer resection in 5 patients for recurrent gel now. I ended up saving recurrent gel for all these 5 patients. Sacrificed in 2 because it was involving cricotracheal, and I didn't know how to go with the intralaryngeal release. You need to have a good patience to do intralaryngeal re-nervation, which I didn't do it. I thought I could have done it. Mortality was seen in 2 patients, one with the window resection on post-op day 45, and the other was anaplastic, which succumbed to disease after 7 months. So for this 1 patient with window resection on post-op day 45 is a patient who came with a papillary cancer, locally advanced, but patient came in stridor, and on doing an ECG, stress to deco showed a 3 vessel disease, a Dobedon stress test. So we had to do CABG with the thyroid surgery. So patient underwent CABG. The surgery went on for 4 hours. We protominated. We took the patient. We started doing a tracheal resection with thyroidectomy. So thyroidectomy done total, bilateral central compartment, neck dissection bilateral 2 to 5, and we found that there was no intraluminal involvement, but shave resection was not visible. We were living behind disease. The patient did not have distal met. We did a window resection. Since it was 3 ring resection, I did a PMMF. I also did a tracheostomy lower down, and we shifted the patient to ICU. Patient was doing fine, but because of extensive resection, he went into a critical illness syndrome, what we say is, and what we found in COVID typically, that kind of a critical illness the patient had, and somehow patient had a mediastinitis and patient went into a sepsis, septicemia, multi-organ failure, and we lost him. So mortality, 2 patients, complications, bilateral ligament palsy in 1, that was in 1 patient with window resection. The rest remaining 5 patients are surviving. We are collecting more data. We are still doing more and trying to publish this. Of course, with all the variables we are trying to take into account. Thank you so much for patient hearing. Thanks a lot, madam. Thanks a lot, everyone, for listening to this.
Thank you, Dr. Snehal. Actually, a very difficult topic, and I just thought that only Snehal can do justice to this. So I think, Snehal, I think there are 2 questions, I think, on the chat box. One is like, again, excellent presentation, very difficult topic and difficult surgery. Great, Dr. Snehal. So question, can we only release suprahyoid muscle or only, or it has to be removed with hyoid body only? Hello? Snehal, you are muted.
If you so ideally, what we prefer is doing lesser. What we say is doing lesser is more for thyroid. Now, hyoid bone resection, if we do, the amount of length that we get is phenomenal. So what I want to say is supra release will release up to 2.5. I am not going to contest on that, but releasing hyoid will drop the larynx. And the kind of drop larynx that you find is, madam, is something you would enjoy taking sutures posterior to the anterior when you're doing a end-to-end anastomosis. So cricoid, a hyoid is not removed, but ideally it has to be done. That gives a lot of maneuverability for the trachea. The chance of dehiscence goes down.
Correct. So I think whenever you want to achieve this tensionless suturing losses more, you can go ahead and remove the hyoid safely and do it.
And ma'am, no harm in resecting the hyoid body, because that is same thing what we do for cyst trunk also. So the mobility that we are giving to the patient is not much, but the laryngeal drop that we are getting is phenomenal.
Correct. So I agree. So whenever possible, do it in a safe manner. Just expose the hyoid bone and remove the body, and keep, like Dr. Snehal said, keep the cornues intact. So that the complications are not there, because with body there's nothing which actually can happen. So the nerve, the vessels, I mean the lingual artery, everything is far away from the body. So one can easily do it. So another question, Dr. Snehal, feeding through feeding tube just 4 or 5 post-op day, or through mouth? They say just after operation. What do you suggest?
So ma'am, a couple of issues when we are dealing with this. The reason is that when you've done this much, that is, we don't know, even though we have preserved rectal nerve, how is it paretic or it is undergone a palsy. So for me, it is at least 2 weeks that I keep it. So I go extra, I go very conservative with my feedings. I do not start immediately. If recommended is 7 days, I take 14 days. I do not start immediately with the per oral. I always start with the Riles tube feeding. The reason is aspiration. If happens, my surgery is going to get spoiled. My outcomes are going to get affected. So let it heal properly and then we start. So no harm in keeping for 2 weeks and then starting, rather than removing immediately within 5-7 days. Although it is indicated by 5 to 7 days you do remove, and patient have started feeding well. But I take my own time now.
Yes, I completely agree with you on this, Dr. Snehal. One more, like one presenter has shared this experience that last 18 July, they had done tracheal resection and anastomosis. The lower margin was R0, but the upper margin was at the cricotracheal joint. So they assumed that it was a positive margin. So should they attempt to go ahead with the R0 resection at the entry point of left, as the entry point of left recurrent laryngeal nerve was damaged? So that's why they compromised the R0 resection.
I read, ma'am. So I would ask, what was the pathology? What was the biology that we're dealing with? What was the tumor burden? How old was the patient? So initially we need to prognosticate. Can we sacrifice one recurrent angina? Now, if that is the only site of disease, yes, I would resect. I would not think about, but I would do a step like resection, try and preserve the opposite side recurrent angina. So yes, I would resect and get a R0. Getting R0, I'll tell you why. What are the other modalities? People, the philosophy is do a R0, or if you give R1, start with RAI or radiotherapy. Now, if you see, these tumors are radioiodine resistant. So the NIS mutation is present in almost all. So the amount of radiation that this patient take is going to be lesser. Eventually, you will end up with the progression of disease and laryngectomy. One. Second modality that we have today is radiotherapy. Now, radiotherapy, again, retrospective study, is it really going to be helpful? Yes, there are studies which show benefit in locally advanced. But again, why should I use that option when I can give a good rehab to a patient with sacrifice of single RLM? So I would go ahead and do. But there are multiple distant metastasis, meaning lungs are studied, so is the bone studied. I would still like to keep the disease there and go ahead with the other treatment rather than going ahead with resection of RLM and give morbidity. So what perspective are we giving is with respect to other factors. We need to prognosticate this patient and we need to decide as to when we want to resect. I would go ahead if that's the only behind.
Correct. So I think Dr. Snehal, last question. How is the take-up rate of rib cartilage if taken along versus along with PMMF?
Pardon, ma'am. How much is
how is the take-up rate of rib cartilage? Like how if taken alone versus along with the PMMF?
So I did one patient with PMF, the other with the costal cartilage, because the resection was lesser. So when you have lesser rings, you close PMF airtight. You don't allow it to sink in. But if the resection is also involving lateral and the anterior wall, you would will put a costal cartilage. The idea is that the perichondrium of the costal cartilage is inside and the muscle is outside. Now, if but the costal cartilage has got the epithelium which is different, you are going to have a lot of bronchoscopies, lot of clearance of secretions and all. So the pickup rate is good for both, but the indications are different.
Yes, we can hear you, Dr. Snehal.
The indication rates, indications are different for both. For a larger defect, I do put something rigid. So either costal cartilage or I use costal cartilage, but people also use, so one's own autologous cartilage is always accepted. It does give with a good rigidity, but again, it requires multiple bronchos. So the acceptance is good, but the care that you need to take, a bronchoscopic, multiple bronchoscopies to clear out secretions, scabs is quite high. So every 4th, 5th, 7th day you keep on doing. Initially you call every 4 weeks once the patient, and then you call every 3 months and then 6 months. So this is there.
So
the take rate is good for both as long as it's autologous.
Correct. So I think so. With this, we conclude today's lecture, Dr. Snehal. I once again thank you so much. It was a great lecture. Difficult topic, I would say, and you had such an in-depth knowledge. I think everyone learned a lot, and including me. And so I once again thank you. Now we conclude the lecture.
Thank you, ma'am. Thank you so much. My pleasure. My honor. Thank you, ma'am.